So today's topic is syncope, and not so much on dizziness, but that's also included in the presentation. I think most of you have had a chance to hear me speak before. I know that I'm associated with the University of North Dakota School of Medicine, and I oversee the Department of Geriatrics here at UND. And this program is brought to all of us through a very generous grant from the federal government, from HRSA, Health Resources and Service Administration, with the so-called GWEP, the Geriatric Workforce Enhancement Program. So if you ever hear about GWEPs, GWEP, that's the HRSA program that is supporting this education. All right, so let's go to the next slide here. Today we want to talk about why people lose consciousness and why it occurs more in older adults than in younger adults. Although I have to say there's somewhat of a bimodal curve. Teenagers tend to have syncopal episodes about almost the same rate as older adults, but age is a risk factor for syncope. Want to look at how syncope is worked up, and then what are the potential interventions. And I'm just going to preface it by saying that 40% of the time we have no clue what causes the fainting spell or the syncope. You're going to see a lot of artwork for those familiar with my interest in aging in art. You'll see a lot of references here. So, you know, the sensation of falling, Icarus as he's falling down from his melted wax wings. We can consider syncope as a transient loss of consciousness, and it's associated generally with a blockage in the blood flow. So it's called hypoperfusion. Syncope will occur in about a third of the older adults, sometime during their lifetime. I'm actually one of those in that party. I was on an airplane, and I went to the washroom, came out of the washroom, and passed out right into the arms of a airline stewardess. And it would have been a glorious moment in my younger days, but being the age that I am, was a little bit of an embarrassment. So the syncope does increase with age, and it is a very common reason why people end up in the emergency room, and many times appropriately so. Fainting spells or syncope can also occur in long-term care, and for those that have had an incidence, a third of those will have another occurrence over time. And we can have a conversation about why syncope occurs so frequently in long-term care, but suffice it to say at this moment that medications and lack of hydration are often the driving forces behind syncope in either nursing homes or assisted living facilities. And that's compounded by memory loss, where people don't really have a sense of thirst. They don't have a sense of smell as a result of Alzheimer's disease. And so there's a lot of lack of intake of fluids. So I mentioned young adults, teenagers have a spike in syncope, or usually it's vasovagal episodes. And then you can see as people get older, over the age of 75, it occurs quite considerably more. So here's from the Irish longitudinal study. It shows that basically when we hit middle age, that syncope occurs at a pretty steady pace, throughout all the age groups. However, falls tend to crescendo at the age of 75. And so why do we show this comparison? And admittedly, this is a study that's limited to a population of Irish and not necessarily of other races and backgrounds. And so, but it still represents this notion that when you are just before the average life expectancy, there's an awful lot of falls. and the fall rate tends to decline after the age of 75, and for reasons unknown. So you might ask as to why syncope occurs, what's behind it. And so, as mentioned earlier, the blood oxygen decreases. It might be the heart rate slows down considerably. I always scare people when I go into the clinic because my heart rate is 42 to 44 beats per minute, and they wonder if I'm dizzy. And generally I'm not. But my beta blocker really slows my heart down pretty good. And that's always a possibility, is that slow heart rates can cause syncope. Low blood pressure, and we'll talk about that. Low blood volume from inadequate taking of fluids, may be compounded by a water pill, Lasix, or hydrochlorothiazide, chlorothalidone, and also the combination of hot weather. So if you got older adults going out into 90-degree weather like today, and they happen to be on a water pill, oh boy, that could be a problem. So that could really reduce the blood volume. Cerebral blood flow, and people always say, oh, you had a stroke. Well, it could be a stroke, but generally to get a syncopal episode, you have to have the blood vessels on both sides of the brain get knocked out, and that's pretty rare. So it turns out that as we age, just the physiology is such that we don't recover so well when our blood pressure is perturbed. And so what happens is that we get an overall lower blood volume as we get older, because of the kidneys get rid of the salt in a way, and they don't retain the salt as readily when the body's under stress. And then there might be a problem with the heart. Most typically, everybody over the age of 65 has some form of diastolic heart failure. And again, the ability to compensate for a drop in blood pressure is not as vigorous as it may have been when we were younger. So, and part of the reason is that the heart gets less compliant, the heart is stiffer, it can't accept as much blood, and then it cannot eject as much blood as a consequence of that stiffness. It's all part of that element that we've talked about previously, is that tissues that are supposed to be soft get harder, and tissues that are supposed to be hard get softer. The aging heart rate is something to consider, and we'll see a little bit here, but it's slower to compensate with stress. And so what is the stress? The stress may be a drop in blood pressure because you're dehydrated and the heart rate doesn't go up as fast. And it's the same reason why when people get sick, whether it be COVID or a bacterial infection, we may be fooled clinically because their heart rate is not beating so fast, which you might see in either sepsis or a viral infection. It's because their heart hasn't compensated quite yet. And by the time it does compensate, they could be in very, very serious trouble. The other point here on this slide is that orthostatic blood pressure changes may persist for a longer period of time. And I'll show you some data that helps support that when people go from a supine to an upright position. And a lot of times people say, I kind of feel lightheaded when I get up out of bed. That's a pretty good history to look further into whether they have orthostatic blood pressure changes. So there's a half dozen of issues that could be related to syncope. You can see here, and I think the bottom right-hand corner here, the multifactorial reason is probably wins the prize here, just because that's usually the case in most cases. Why do people fall? It's multifactorial. Why do they have syncope? It's multifactorial. Why do they have failure to thrive? It's multifactorial. So that one kind of rules the roost here. Yeah, so this is the TILDA study. So this is the Irish study. They had like close to 3,000 people enrolled in this study, and it's wonderful. Just looking at the physiology, and what you can see here is the systolic blood pressure, which is on average was the zero starting point. So it's not the actual blood pressure, but it's the what the average was. And then what they wanted to do was identify how low the blood pressure went. And you can see it dipped pretty good on average, well below the 20 points that we consider to be positive for pathologic orthostasis. And so these are by and large normal people. So you can see on a tilt test, and we don't do tilt test, right? I mean, we do it, but it's in a cardiac setting. It's not like we're doing those in the primary care clinics. But you can see how dramatically the blood pressure drops. And then it takes, looking there, it looks like it takes about 10 seconds for it to recover. And it gets worse as people get older. And so that process of recovery goes from maybe 5 to 10 seconds to now 10 to 15 seconds. And so we now can see a window of hypotension that could lead to any number of things, such as syncope, for example, or wobbliness with a fall. So it's this distance that you see between this dip that really dictates the consequences of this drop in blood pressure that occurs normally with age. And you can imagine how this might get even worse if you add diuretics. You've got somebody on both a beta and alpha blocker, so somebody that's on something for the prostate, and then a beta blocker for their coronary artery disease. They're a total setup for a very prolonged dip in their blood pressure, going from a supine to an upright position. Yeah, so I mentioned this earlier, this sort of, splatter art from Jackson Pollock. This is kind of how syncope works. We don't always get at the root cause of it. So that's kind of the disclaimer here. So if we look at the different reflex syndromes that are associated with syncope, probably the one that we're most familiar with is the situational faint. Sometimes it could be brought on by a pretty vigorous sneeze or cough. I have a brother-in-law who sneezes very vigorously, and it scares the living lights out of everybody in the room because it comes so unexpectedly. But that's his, signature there is very boisterous sneezing. He has not passed out as a result of it, but, I'm waiting for the day. A big one is post-micturition fainting, which can occur with prostate hypertrophy and outlet obstructions, and then post-exercise. So somebody that maybe got dehydrated. I had a patient that came into my clinic, 90 years old, running out in this 90-degree weather, and his son who was with him reminded him, he says, "Dad, first off, you shouldn't be out running in 90-degree weather, and then secondly, you didn't bring your water bottle." So touche. Two indices for post-exercise syncope. This is a big one. This topic of postprandial hypotension. It usually occurs in the frail older woman who typically is underweight, and it will occur approximately within an hour after eating, and usually eating a larger meal. And so in some long-term care facilities, they'll find that the biggest meal during the day is lunch, and they would have a lot of older adults that would collapse after lunch and couldn't quite figure out what was going on. Well, this is one of the reasons, is that it's kind of like the old adage that I recall from my mother saying, don't go swimming after you just ate, because all the blood's going to go to your stomach and not to your brain, and you'll pass out. A little bit of folksy medicine, but probably very very true to the point that that there's redistribution of the blood flow. In terms of orthostasis, we mentioned that age is a risk factor. Also kind of implied, and we'll state very explicitly, that medications such as diuretics and combination sympathetic blockades with both alpha and beta blockers. Sometimes people have autonomic nervous system failure. We'll see this in Parkinson's disease a lot. And then just, not enough water in the tank. So volume depletion can all set you up for orthostasis. Arrhythmias, and this reminds me, happy Juneteenth Day to everybody. I would love to see if this reminds us of our freedoms, and so that's about as political as I'm going to get. And we need to consider in syncope a slow heart rate as well as a fast heart rate. And so a lot of times people will get a fast heart rate, and it's called a atrial fibrillation with a rapid ventricular response. And a lot of times that's associated with dizziness and syncope. Supraventricular and ventricular tachycardia arrhythmias are always very ominous. Well, the VTAC is the SVT, not so much unless it's what we call sustained. And then also the pacemaker kind of poops out. So that's another reason that you might have a syncopal episode. In terms of structural heart disease, most commonly it's the blockade in the aorta. So aortic stenosis can cause syncopal episodes. What we call obstructive cardiomyopathy. So the heart is thickened, and if it starts to go where you need a lot of increase in heart rate, it then starts to obstruct because it's squeezing the heart faster, but not completely. Pericarditis, from either a virus or from inflammation, from like rheumatologic disorders, lupus, rheumatoid, and so forth. Those can cause constrictions and fluid around the heart that can cause the heart not to function. If you have a blood clot to the lungs, pulmonary embolism can cause syncope, and that's actually one of the first things that I think of when somebody comes well, I don't work in the emergency room anymore, but that is first on the list. And then also myocardial infarction. Sometimes there could be loss of consciousness associated with a seizure disorder. Sometimes people have what's called vertebral basilar artery insufficiency. A lot of times what will happen is that they'll lift their chin up looking up at a cabinet or looking up at the sky, and they pass out. And that's because the arteries in the back of the neck aren't flowing properly. Sometimes syncope can be caused by metabolic disorders like low glucose, as an example. So we want to move now towards the workup of syncope. Certainly just getting the history and physical and asking what the circumstances are for the dizziness or for the passing out. It's almost mandatory in a geriatric clinic, if you're looking at folks over the age of 75, that you do an orthostatic blood pressure check. A lot of times people are asymptomatic and they still have orthostasis. I like to do an ambulatory pulse ox because if they start to desaturate with walking 50 feet, that could be another indicator for why they're passing out. Baseline EKG or ECG, where you're looking at either the PR interval or the QT interval, because prolonged QT interval can be associated with malignant arrhythmias. We don't typically do carotid massage, but that is part of the initial workup. I don't know. It just there's a very small risk of stroke, if you massage somebody's neck and they have an atherosclerotic plaque. So I tend to stay away from that. So the strategy is basically to break it down. Is it a cardiac event? Is it a neurogenic event? Something with the brain, and or is it other? And for the first time here in our discussion, I also want to include the psychiatric aspects of syncope. Back when I was coaching youth basketball, elementary school and junior high, we had one of our players was notorious for passing out when the player wasn't doing so well on the court, and so there'd be this big dramatic scene of this player passed out in the middle of the court, and finally the dad said, "If you do that one more time, you're never going to play basketball again." And I guess that was the last time that we had a pseudo syncopal episode. So maybe a little too much detail here, but if you suspect the heart, you'll see people order a Holter monitor, also to get an echocardiogram to look for those valve issues. Typically, they're obstructed valves more commonly. the aorta than in the mitral. And sometimes, even though it says step 2 that you go through an electrophysiologic study, I actually think that that's step 4. Quite honestly, unless you see something in the EKG that suggests that you should do an EP study. And then in the cardiac lab, you'll do a tilt test. They'll also do adenosine intravenously to see if they can induce an arrhythmia. And then some of you may have heard of the ZIO patch, the ZIO, which you can now wear for 2 weeks, and that sometimes will identify arrhythmias. But I'm telling you, even a 2-week, it used to be 48 hours. We used to get a Holter. Now we can get it for 2 weeks, and sometimes even 2 months, and you still can't find any arrhythmias that are associated with the syncope. If you think it has something to do with the nervous system, you can do an adenosine test and a tilt test. Again, these need to be done in a cardiovascular lab is my recommendation. And then very similar testing as you would for cardiac. Yeah, so this is a good example of where the person was injected with the adenosine, and then the atrial node gets blocked. You can see these P waves, and they're not transmitting any QRS complexes. So there's a sustained block, where, so you get different degrees of heart block as a consequence of the adenosine challenge. I want to move now toward the more common. So we're moving from neurogenic and cardiogenic reasons for syncope to more mechanical or orthostatic hypotension. And so you can see, depending upon the study, up to a third of community dwelling older adults have some form of orthostatic hypotension. And then 1 out of 10 frail older, and I emphasize usually frail older adults will have this so-called postprandial hypotension. And then the fact that frailty amplifies hypotension, and I described that earlier. So one of the things is that age reduces the heart rate recovery from orthostatic blood pressure, and you can see 40% of 80-year-olds are not fully recovered after a couple of minutes after you do that, supine to lying, or lying to standing, position, or it could be lying down to sitting up. And in fact, if you're in the hospital setting, you can have the patient take their blood pressure while they're lying in bed. And then if they can't sit up, you can have them dangle their legs over the side of the bed. And that's sufficient to take an orthostatic blood pressure. So as mentioned that, changes in blood pressure and particularly hypertension increase the risk of hypotension. And the reason being, as I mentioned earlier, is that you get more non-compliant arteries. The heart doesn't accept as much blood as it used to. The baroreceptors have become insensitive, and and then also just the general what we call autoregulation. The brain does everything it can to keep the circulation going, and it just doesn't always keep up with some people as they get older. So we want to drill down into the drop in blood pressure or the orthostatic history, find out when the dizziness occurred. Sometimes just fatigue, I'm feeling tired is representative of a low blood pressure. Actually, that happens to me. Like if my blood pressure drops below 90/60, I feel like I got to go to sleep. And it's that fatigue sensation that can be associated with hypotension. Sometimes blurry vision, also by hearing problems, and these are intermittent hearing problems, not continuous. Sometimes can precipitate back pain, sometimes stomach pain. So low blood pressure that somebody has atherosclerosis in their superior mesenteric artery. Sometimes that can cause stomach pains, particularly after you eat. And that also may be associated with orthostasis. I'd mentioned about the autonomic nervous system failure. So there's a variety of categories, but the one that I want to point out is number 3. It's called the Shy-Drager syndrome, and it's most commonly associated with Parkinson's disease. So, as Parkinson's disease is associated with a midbrain neurodegeneration, part of that neurodegeneration involves the autonomic nervous system, and so you get things like constipation, early satiation, your stomach doesn't contract as well, maybe sometimes urinary retention, and then certainly, with constipation and drop in blood pressure. These are all signs of autonomic neuropathies. So if you're looking at just non-Parkinson's, so what we call pure autonomic failure, autonomic nervous system failure, you'll see things like constipation, as well as not the inability to sweat, and then you'll get this blood pressure changes. A lot of times this is associated with low blood plasma catecholamines, such as epinephrine and low norepinephrine. Don't want to spend a whole lot of time on multiple system atrophy. It occurs at a noticeable rate. It kind of looks like Parkinson's, and it's more related to progressive supranuclear palsy. So it's a little different prognosis and a little different representation, and typically it's not responsive to medications. So the orthostatic changes in Parkinson's disease, more commonly seen in people that have memory impairments, and certainly the medications can cause, such as levodopa, can cause changes in blood pressure. So again, medication associated with some physiologic and disease-related changes. So this is really a huge point to emphasize, is that alpha blockers, particularly those that are in association with beta blockers, the combination together can often cause syncope. Anything that causes loss of water and salt, such as the ACE and angiotensinogen receptor blockers, calcium channel blockers, particularly the first generation, are very, very potent vasodilators, as are nitrates. And in fact, the sildenafil and all the erectile dysfunction medications are contraindicated when in men who are taking nitrates, because it causes vasodilatation and then therefore causes syncope and fainting. Probably this medication, I don't see catapress or clonidine, that in the middle there. I don't see that being used as much, but that's notorious for causing central beta blockade and alpha blockade. It blocks both the alpha and beta blockers and can really be a pretty nasty medication in the older adults. The anti-arrhythmogenics, so amiodarone has been linked to syncope. Sometimes it's associated with causing factitious or doctor-induced hypothyroidism. So we always have to be on the lookout for that. Medications that are linked to syncope are the tricyclic antidepressants, some phenothiazines, and certainly the SSRIs, particularly those that, if they're associated with low salt or hyponatremia, which occurs in just under 10% of the time. And my favorite label for beers, not that I've ever tried this, is delirium tremens. I think it's from Holland, I don't know, somewhere in Europe. But alcohol in itself can cause syncope for a variety of reasons. Again, multifactorial. It could be from dehydration. It could be just from drunkenness. It could be from cardiorhythmic events, because alcohol is cardiotoxic. So again, multifactorial. So as we try to make the diagnosis, we have to turn to treatment options. And if we know, for example, that there's aortic stenosis, then the option would be aortic valve replacement. There's a whole controversy about TAVRs, TAVRs, as to whether they work over the long run. In terms of other treatments for cardiac arrhythmias, you try your best to titrate medications to suppress You don't always get rid of all the arrhythmic events, but you try to suppress it. And then the big catch category here is the multifactorial. And so adequate hydration is important. And if you suspect there's a certain medication, like as I mentioned, the combination of, let's say, terazosin for prostate hypertrophy plus a beta blocker, you might want to switch the terazosin to another medication for prostate hypertrophy. Compression socks are important to help get that oomph out of your circulation when from the sitting or supine position going upwards. I also advocate preambulation leg contraction, so I just call that toe tapping. So once you stand up, if you have a history of getting a little lightheaded while you're standing up, certainly have the compression socks on, and then do a little toe tapping to get the venous circulation going. Avoid sedentariness. And so we know that astronauts get orthostatic hypotension when they go into outer space. And it's because they're pretty much in a resting position. They're not really very active. So too here on Earth, we need to avoid sedentariness. In terms of the management of orthostasis, some of the things that we want to consider is avoiding large meals, so frequent small meals. The overheating, don't go outside like on a day like this. Avoid hot showers, no hot tubs, and so forth. If you're having issues with straining during defecation or urination, certainly have the physician address that, or the provider, is to either stool softeners or sometimes just straight catheterization. Self-catheterization is a solution. Modest use of alcohol. I had a patient who I prescribed for her cholesterol, a 6-ounce glass of red wine every day. And she says, "You're the first doctor who's ever prescribed wine for me." And I said, "Well, it's actually one of the recommendations from the American Heart Association for people that have low HDL. But again, you don't want to overdo it. Isometric exercises, so sometimes, where you're like really like pumping iron and, you're holding your breath, those are not good things because those can cause vasovagal episodes. And again, the last point, making sure you're adequately hydrated. For those that have idiopathic or that Shy-Drager syndrome, there's a variety of things to do, but the bottom line is that the knee-high compression socks aren't as good as the waist-high compression socks. So always remember that if you have somebody with, bona fide orthostatic hypotension, it's really to have above the knee compression socks. Physical conditioning can really help an awful lot, with good muscle tone. Habituation therapy through what's called postural training. And then we typically tend to liberalize salt and fluid. I can't tell you how many patients I've seen in my geriatric clinic that have orthostasis, and I immediately go down and buy them a bag of potato chips. Again, you don't want to do that if they have systolic heart failure. Excuse me. Okay, so just to summarize, we know that syncope is common. And it's always importantly, the first thing you ever do if somebody has a fainting spell is to check their orthostasis and also ask the question if their blood pressure dropped or it was associated with an eating event. And then aside from orthostasis, we then start thinking about arrhythmias versus a transient ischemic attack as a consequence of the syncope. But more commonly, it's either orthostasis or the last point there, which is medication side effects. So that's always the go-to question as to whether they're on a diuretic, alpha beta blockers, or or any of the other medications that I had mentioned earlier.